My name is Dr. Hussein Kandil. I am a urologist specialized in male reproduction and sexual dysfunction, or what is known as andrology. I am working currently at Fakih IVF Fertility Center in the UAE. Yes, first of all, I would like to thank MedSynapse for hosting me today in this interesting topic, which I believe is fundamental in our current times, knowing that the incidence of male infertility is on the rise. Now, this brings me to answering your question, which is really interesting, which is the challenges. There are things that are patient dependent, knowing that the male patient tends to see fertility issues and sexuality in general as taboo topics, and they tend to refrain from seeking medical advice on timely fashion. And needless to say that mostly there are lots of risk factors that are available within our community and within our lifestyles that many of those gentlemen are exposed to on a daily basis. And the lack of awareness and lack of knowledge makes them actually presenting at a late interval. One other thing would be the fact that they don't know where to go, and this is part which is related to our medical community to raise awareness. They don't know to which doctor they should seek, and they tend to go to gynecologists or endocrinologists, but they should be aware that there is a reproductive urologist who are doctors specialized in exactly the same problem that they are suffering from. So the challenges are many. That's because it's just an evolving field of medicine, but part of it is in our shoulders that we need to increase awareness. Yes, so it's same as with any other medical problem. So we tend to meet with the patient physically, which means that we talk to the patient, take history, because that's really influential. We get much insightful information from that, whether the infertility is something new or something has been there since a long time ago. Does he have children or not? Are there any associated symptoms that can explain exactly what's going on and can help me narrate a diagnosis at the end? What kind of lifestyle the patient tend to get exposed to in terms of risk factors? Is the patient on medications? Is the patient during his work being exposed to any kind of hazardous exposures? And so many questions that in general, from just doing a history taking and interrogating the patient, we get to know lots of information, and then we shift into the physical examination, and that's really interesting. That's because I would say more than 30–40% of the diagnosis would be revealed by just examining the patients. Lots of genetic problems and lots of things that are rare to find and rare to discover just by talking to the patient could be discovered by doing the physical examination. And this, at that point, I believe any healthcare physician should be, able at that point of time to identify the real problem, at least within 70–80% accuracy. And then we shift into the investigations, which are commonly a semen test and a blood test. Semen test it's also known as a sperm test. That's just, we need to look at the sperms and look at the production and look at the quantity, the number of sperms and how vital they are, how fast they are moving and how do they look. And in addition to a blood test, which reflects the hormonal profile of the patient. That's because there's a lot of correlation between hormones and sperm parameters. At the end, if anything other than that is needed, we can request it. But I believe by just doing these very basic things, we can reach at some point to delineate what's the problem with the patient. So this is also interesting. That's because at some point, most of those patients have things in common. And then we start to tailor the therapy based on the specific outcome or specific situation of each patient. The common ground includes, behavioral modification, improving lifestyle, refraining from certain exposures, advocating healthy lifestyle, encouraging exercise. So these things are fundamental to any male patient presenting for fertility problems. But then in terms of specific issues presented by the patients, each patient should have a plan. That is because each patient can present with a specific set of problems, whether it is a genetic issue or a hormonal issue or simply an infection, or simply it's nothing, it's just a timing issue. So we tailor that based on the outcome. So in general, unfortunately, genetic problems tend to be the most serious forms. That's because we cannot manage that, or we cannot treat it or cure it. We can just manage it in terms of helping the patient overcome this genetic problem to, at some point, have a baby. Now, this is so challenging, but it requires some time with those patients so that they can get over that. And then acquired causes, if there's anything unusual with the blood test, and most commonly we are referring to hormonal problems, low testosterone, which is the essential hormone responsible for masculinity and fertility in general. It's essential for sperm production. So patients with low testosterone should have treatment to improve their testosterone levels. Patients presenting with infections, they should receive the proper antimicrobial so that they can improve the sperm parameters afterward. Patients who've had or are having varicocele, which is dilation of the veins around the testes, which tends to heat the testes. These patients should be subjected to surgery. Patients with no sperms in the ejaculate, also known as azoospermia, they should opt to do sperm retrieval procedures, especially the microsurgical technology. So it depends which category is the patient, and then we start to shift from one phase to the other. So this is the best message I need to convey to the people. That's because the word infertility nowadays is not really an accurate term. That's because infertility is a definitive term. However, with the technology that we have, with the chances that we are experiencing day after day, we tend to see that those patients who've been categorized in the past as being infertile and they were just sent home are now having higher and higher chances day after day to father children. That's because the advance in research has started to kick in, and we can see on a daily basis new reports and researches that are evolving. On the other hand, the advancement in artificial reproductive technologies like IVF and ICSI, this had opened a chance to those patients with the minimal number of sperms, even if it's just a dysfunctional, weak and poor sperms, they can still manage to have a baby. So in terms of chances, it's really high. So with therapy, studies have shown that many of the patients who are presenting with, let's say, for example, hormonal problems, they tend to be managed easily. With a rough estimate of 90% of those patients can fix their hormones. Now, hoping this would translate into seminal improvement, which means increase or improvement in sperm count. This is also available. We have seen that patients who've had medical therapy have shown significant improvement in semen parameters. Not only this, so patients who have the most serious form of male infertility, which is azoospermia, they don't have sperms in the ejaculate. One study have shown that with appropriate treatment, you can have sperms in the ejaculate back again in 10%, and success of sperm retrieval surgically up to 50%. So now we're talking about opening up to those patients and letting them explore the opportunities. There's nothing to lose at the end, but the chances are always on the good side. So varicocele, to define in the beginning, is just dilation of the veins around the testes. Normally, the veins, they have valves to prevent the flow of blood in both directions. So it allows the blood to move downward, upwards. With time or with risk factors of standing, holding heavy objects, and with specific predisposition, patients tend to have dysfunctional valves, and then the blood starts to flow upward, downwards, and downward, upwards at the same time, which results in stagnation of the blood around the testes. It doesn't really move anywhere. With time, those veins start to enlarge. And the fact that there are veins down there engorged with blood, it means that there is heat being transmitted to the testes. That's because the testes are normally being put outside the body, and actually it goes outside the body to lose temperature. The functional temperature of the testes is much less than the core body temperature. So imagine the testes is now surrounded by a network of veins with the core body temperature. So it starts to heat it up. And not only that, varicocele, with this kind of engorgement of blood around the testes, it starts to release substances that we call oxygen radicals, which deform the DNA of the sperm, which we call DNA fragmentation. And all this would result at the end in poor sperm production. Now, varicocele is the most common reversible cause of male infertility, which means by correcting varicocele, which is usually surgically, you can expect improvement in semen parameters. Now, unfortunately, not all varicocele surgeries would result in significant improvement. That's because, sometimes we still don't know, but some patients would still have varicocele and be able to have children and not even suffer from male infertility. So it's a bit of a paradoxical, but in general, what we tend to do according to the guidelines, that if a patient is presenting with infertility with any unusual parameter within the semen, and an associated varicocele, it is recommended that it should be treated, regardless to the grade. But for sure, grade 2, grade 3 are more advanced grades, and it warrants, more serious approach. So varicocele is treated surgically, and preferably a microsurgical technique. And it's an easy procedure, and many patients would just do it and go back home on the same day feeling as if, it's just a small incision, no pain, nothing at all. So with this being said, varicocele is to be considered for all the patient entities suffering from male infertility, in addition to abnormal semen parameters and clinical or radiological diagnosis of varicocele. This is so interesting. That's because I tend to believe that the coming era is going to be the gene therapy kind of thing for male infertility for the more resistant cases. In the beginning, we talked about the etiology of male infertility and big percentage of it, and it's not really uncommon that genetic causes are in the top list, and these are the most serious forms. We know about them. But we don't know all other genetic disorders that can cause male infertility. But nowadays we have markers, which are genetic tests that we tend to do to help diagnose and, get to know which type of genetic trait is there, so that we can try to prevent it in the offspring by doing genetic screening on the embryos if the patients or the couple would elect to do IVF. So let's say the most common problem is called Klinefelter syndrome. It's really common, and it's just that we have one extra X chromosome resulting in a 47 total number of chromosomes instead of 46. Another problem that is fairly common, that is the Y chromosome microdeletion, which means the Y chromosome, which is responsible for the development of the testes and the masculine feature of the male, tends to be broken, or a part of it would be dysfunctional, and that's what we call Y chromosome microdeletion, and this would result in a serious form of infertility. So by getting to know these two, for example, we can get to know what's the chances of fathering children, and what ideas that we should share with the lab while doing IVF, so we can just try to prevent that. Other problems that we know about, like patients with obstruction, they don't have a vas deferens, and these entities are linked to a serious genetic problem that is called the cystic fibrosis disorder, which is linked to a kind of mutations in one of the genes called CFTR gene. Now, the importance of that is we need to diagnose it so that, for the children, if it happens that both partners hold the same carrier gene, then there's a chance the child would be diseased by a bigger form of disorder. This brings me to answer you in general that yes, genetic markers are very essential. And I believe in the future, we're getting to know more and more about that. And there will be more availability. That's because it's not available everywhere. Even nowadays, it's expensive. It's not really easily to find a center or a lab that would do genetic testing. But we hope for the future, because I believe this would hold the greatest success, in terms of treatment of male infertility. So, Clamophian citrate and tamoxifen are also known as selective estrogen receptor modulator SERM. This means that these agents can act as estrogen agonists, which means that they activate the receptors, the estrogen receptors, or they can be estrogen antagonists, which means that they block the estrogen receptor. So being selective, it means that it could act both the same way. Now, Clamophian citrate has been used since ages, and when it was initially manufactured, it was initially directed to the females, and it tends to improve ovulation. And that's why the leaflet within the medications are generally directed to the female. But later on, they discovered that having had, the males and the females with different gonads, the ovaries and the testes, they function different, but they respond with the same manner when they receive those kind of treatment, which means that they get stimulated. So they started using clomiphene citrate and tamoxifen to the males to boost the production of testosterone and sperm parameters. And till the moment, it's one of the most commonly used medication in male reproductive field. It's a very safe medication. It acts at the higher centers in the pituitary gland and the hypothalamus, so to increase the release of gonadotropins, which are that kind of messenger hormones that send a signal to the testes to increase the activity of specific set of cells to make more testosterone. And by the fact that your testosterone is going to rise, with time we can identify, increase, and rise in sperm parameters. So it's a very commonly used medication and it's safe. And actually, I always tell my patients, don't try to read the leaflet because it's mostly for the female, but it's being used as an off-label with the males. Yes, certainly. So the two big schools in the world, that's the American Urologic Association, which regularly tends to release reports and guidance for clinicians so that they can just get to know how to step from one step to the other based on researches. And there's a lot of things that have been updated constantly, in addition to the European Association of Urology, which also has dedicated an enormous research on male infertility. So in terms of guidelines, it's available. And what's more interesting is the rate of publications, which actually is super speedy. And for whoever is interested, I believe that they should also focus on what's being released nowadays, because everything is just new. And I believe in the coming years, it's everything that we're doing nowadays is going to be part of the past. Well, I believe this question is the essence. What we're doing here, or whatever our practices are, they rely mostly on patient education. That's because it's really interesting that before being a patient, he should be aware of things that if unfortunately he will become a patient at some point of time. So the level of awareness should be high. And part of it is related to us as clinicians and researchers, that we need to raise awareness for those people. I wouldn't say patient, just to the male population, so that they can get to know exactly what they're doing and what's the outcome. So first of all, I'll just give an example. For those who use anabolic steroids in the gym, for example, for muscle mass and for recreational purposes, many of them, that's what I see daily in my clinic, many of them are not aware of the contraceptive effect of steroids on their health, and they regret receiving that in the beginning, claiming that they never knew that. And they wish that somebody would have told them this in the past. So lots of things that require awareness. And in terms of my practice, I tend to spend much time with my patients, hoping that would be a messenger at some point of time to transmit and convey this piece of information to others. But in the other, with this our lifestyle right now that we're living in, sorry, stop.
Yeah, sure.
And I would say that we should take advantage of the current situation right now, with people are more relying mostly on social media kind of thing, and they can easily operate there. And we tend to, send messages and signals, whether it's a blog, whether it's an interview or whatever. But we believe that there might be someone out there who would be listening to these, simple words and receive or perceive something good out of them, and, would help him manage something good in his life. But yes, awareness is something that is a little bit missing in our field of maiden fertility. And that's what we're working on right now, using all possible channels to reach people and help them and help educate them about their, reproductive function. Yeah, that's really interesting, because from the very first day, there have been lots of rumors and lots of false information and lots of in medicine, we rely on evidence-based type of medicine, which means that if I want to clarify a scientific fact, I should be backed up by strong literature. From the beginning, people have been concerned about the COVID and its effect on fertility. Well, we really don't know for certain if that's true or not, but what I just advise my patients is just try to protect yourself. Knowing that there's a risk warrants that you should be more cautious and protect yourself as much as possible. But in general, any disease that would cause inflammation in the body can affect semen parameters. So let's say a patient presenting for a semen test, and a couple of days ago he had a fever for just any other reason, you would expect that the semen test would be abnormal at that time. So semen parameters and maiden fertility is a bit sensitive to any kind of abnormalities. So I advise my patients just to get, cautious with everything, whether it's just, protecting themselves, getting vaccinated, because till the moment, the research output is still premature, and we cannot, justify 100% the correlation between fertility and COVID, but at least to be on the safe side, just protect yourself and be cautious. Certainly, technology plays a major role in our practices. Well, to start with, a patient presenting to a fertility clinic is for sure a person who's not really being comfortable. That's because he have taken a decision and he stepped into, beyond the comfort zone, just to declare some sort of agony, and he would, be perceived as someone who is really struggling. So the psychological counseling is mandatory here, and we believe that by doing this, everything is going to be easy afterwards. That's because lots of patients' cooperation with our medical plan is essential. So if the patient is not really at ease and comprehensive of what's going on and relaxed, he would not, help you reach the point that you want to reach. So psychological counseling is really crucial here. And needless to say that the psych in general and the mood issues, they tend to change things organically, which means the hormones, they tend to oscillate significantly with stress, and that would translate into abnormal sperms and fertility potential. So psychological counseling it runs hand in hand along the course of therapy to the very last moment.